So I planned to give this talk about three, 4, 5 months ago, and then just early in February, I saw a patient that made clear why this talk is so important. Click with the mouse once. Okay, so we're going to start out with an instructive patient story. We're going to remind you, and this is going to be the part that you may not like. We're going to go through the physiology of glomerular filtration rate. Then we're going to talk about why we came up with estimated GFR, and I'll go through the history of that, and what the theory is behind estimated GFR. And then we'll give examples of creatinine-based eGFR. And then finally, we're going to talk about cystatin C. So this is a story of a 40-year-old man who has type 4 RTA. Now, this sentence should put fear in your hearts. As the attending, I talked to my resident, Priya, and I said, what's going on? And she says, we have a transfer from vascular surgery for medical management. And I don't know about you, but that's not one of the things I really want to hear about getting a new patient. So I figured, okay, this is going to be really exciting. The next day, the patient has a potassium of 5.8, a bicarb of 17, a normal gap, and a creatinine of 1. Those of you who've round with me know that I'm about to go apoplectic here out of excitement for discussing this case. And the question is, why does this patient have a type 4 RTA? Because by definition, this is a type 4 RTA, hyperkalemic normal gap acidosis. So let's talk about that first, and then you'll see why we get to estimated GFR. So there are a bunch of meds. I don't have all of them here, but it's mostly things that interfere with the development of aldo, whether it's an ACE inhibitor, an ARB, or an aldo antagonist. And decreased aldo is the reason you get hyperkalemia. Tacrolimus can do it. Amiloride and triamterene obviously can do it because they're potassium-sparing diuretics, and trimethoprim can do it in high doses because it acts like amiloride. And that's an important thing that they found early in the HIV epidemic is high-dose sulfamethoxazole trimethoprim for PGA led to quite a bit of hyperkalemia. Second is hyporenin hypoaldo. This is most often in diabetic kidney disease. This is something you see in clinic a lot. Now, sometimes they'll come in and they'll have maybe a potassium of 4.8, and then you put them on the ACE inhibitor and you uncover their type 4 RTA. But the whole idea here is that there's juxtaglomerular apparatus damage. You produce less renin, and therefore you produce less aldo, and it's the decrease in aldo that causes the hyperkalemia. And urinary obstruction. Jeremy Walker, when he was an intern, came up to me after a session at the VA and said, we can't figure out why this patient has hyperkalemic metabolic acidosis. And the patient had normal renal function and was not on any medications. And I said, check and see if it's obstructed. This is reported in the New England Journal of Medicine. Most people forget this, but if you have an unexpected type 4 RTA, always make sure the patient does not have, it's usually bladder and higher obstruction. It's technically not type 4 RTA because it's not involved with hypoaldo. It has something to do with a change in the electrical system. I don't really understand the details, but you'll be a hero if you make that diagnosis. Okay, here's the patient's history. He was type 1 diabetes for 10 years, and his current hemoglobin A1C was 8.3. He'd had a previous above the left knee amputation. His weight was 50 kilograms, and he had a previous creatinine 2 years ago of 0.6. Now, the patient was not on any of those medications, and he wasn't obstructed, so we were assuming that he had a type 4 RTA from hyporenin hypoaldo, but usually those people are at least stage 3A, if not 3B, chronic kidney disease, and you saw what this guy's albumin is, or what this guy's creatinine is. His estimated GFR is 100. 2 years ago, it was 180. When you see an estimated GFR of 180, does that put off warning signals in your mind? After today, anything above 120 should tell you something, and I'll explain what that means, but this is a huge clue to what's going on with this guy. The fact that he ever had an estimated GFR of 180. I have seen at the VA estimated GFRs as high as 300. How many people think they know why that happens? Just raise your hand if you think you know why that happens. Raise your hand if you have no clue why that happens. You never noticed a high eGFR. Good. You should look at it because it tells you something. And most of you will not raise your hand unless I'm giving out awards. And even then, probably not. Okay, that is a clear evidence of decreased muscle mass. Anytime you have an estimated GFR greater than 120, you know that patient has decreased muscle mass for their demographics. Now, that'll become more clear as we work our way through estimated GFR. So we're going to talk about creatinine clearance and cystatin C estimated GFR. His creatinine clearance on a 24-hour urine was 68. So this is lower than his estimated GFR. His cystatin C, and by the way, if you haven't been to the VA recently, you can get it and it comes back in 2 or 3 days. Cystatin C is 1.86. You put that into the formula, his estimated GFR is 37. So now we have a guy who has one estimated GFR of 100, a measured creatinine clearance in the 60s, and a cystatin C in the 30s. So we don't know what the hell's going on. Does anybody know what's going on? I don't know what's going on. Did he have proteinuria? His urinalysis showed no protein, but when we measured it, it was 0.9, which is significant proteinuria and consistent with diabetic renal disease. So we actually think that he had CKD G3B A2. What the hell does all that mean? So G is the glomerular filtration rate, puts him into the 3B category, which is 30 to 44. And the albumin, there's 3 levels of albumin. Greater than 0.03 to 0.3 would be A1. Greater than 0.3, but less than 3 would be A2. Greater than 3, which is nephrotic range, would be A3. Yes. Yes, the dips. So the question was, when I say UA, is that the dipstick? Yes, on the dipstick, there was no protein noted. When we actually sent it out to be measured, we got 0.9. And we had a case, I think last week at Morning Report. Was it either Morning Report or Tinsley Conference, where the exact same thing happened? The patient had significant proteinuria, but the dipstick did not show it. Yeah. Not sure why. So we believe that his type 4 RTA was the standard hyporenin hypoaldo of diabetic nephropathy. We actually sent off both a renin and an aldo, and they were both low. So this guy actually had significant kidney disease despite a creatinine of 1. And that's why it was an unremarkable lab. It seemed to be an unremarkable lab, but in the context of looking at this man, And this man had very little muscle mass, and he had a major amputation. And so he really did have significant kidney disease, and the creatinine can fool you. And that's what I want y'all to understand, is when the creatinine fools you. Because we think that number and the eGFR number really tells us a lot about the kidneys. And on average, it does. And I'm going to say this over and over again. On average, these things are fine. But it's our job to know what's not average. So I want you to understand why we had such disparate values for the estimated GFR, and better understand the assumptions of creatinine-based estimated GFR, and learn when to be that little boy who points at the emperor and says, that emperor has no clothes. When should you say, I can't trust the creatinine? This was a great example of you can't trust the creatinine, because you knew, I mean, we already knew that he probably had a real GFR in the 50s or 60s just because he'd had an estimate of 180 when he was normal. And we could extrapolate from there. Okay, here's the GFR concept. You were taught this in medical school, and many of you have forgotten it. You find a measurable molecule that is perfectly filtered and neither reabsorbed nor secreted by the tubules. You collect the urine for an exact period of time. You measure serum and urine levels, and you calculate the GFR from the clearance formula. What the hell is the clearance formula? This is the clearance formula, UV over P. It could be UV over P of anything that we could use. Inulin is the classic one that is used in research. And the normal inulin clearance in adults is 125. That's normal kidneys, approximately. So if you look at it carefully, the urine concentration times the volume over a period of time is really how much inulin has gone through the kidney and excreted into the urine. And that's as much as has been produced. That's where we're going to get into trouble with creatinine. For research, you can measure it several different ways. And there's some renal divisions who will still do an iothalamate, a variety of these things to really get an accurate GFR. It's really impractical for most clinical use. It's really time consuming and difficult to do. Because of that, the nephrologists went around looking for something that could better be close to inulin. And they came up with the 24-hour creatinine clearance. So when I was a resident, there was no such thing as estimated GFR. Anytime we wanted to figure out what the creatinine clearance was, we had to collect a 24-hour urine. And that's one of the problems. Do you know how difficult it is to collect a 24-hour urine? I know, you write an order and the nurse does it. But ask the nurse how difficult it is. Or send a patient home with a collection and see if you're going to get all the urine. That's one problem. The other problem is creatinine is not reabsorbed, but it is secreted into the urine. And secretion changes between people. It's not consistent. And the third thing that I didn't put on here that I should have is knowing where the creatinine comes from, which it comes from breakdown of muscle. We don't break down the exact same amount every day. So there's variation by days, and I've seen numbers as high as 25% variation. And when you're, so if it's 25% and you get 60, it could be anywhere from 45 to 75. So it's not real precise. And that's one of the problems we have. So they came up with the idea of estimated GFR. The idea behind this is if we can estimate the muscle mass, we can assume that that muscle mass will produce a certain amount of creatinine. and all that creatinine will go out in the urine over time. Let's see if that's what I said on the slide. Okay, comes primarily from muscle. We should be able to estimate that. And UV and cc's per minute for 24 hours can be estimated if we can estimate the muscle mass. Does everybody understand that concept? I'm not saying that you can do it, but that's what all these formulas are trying to do. Does that make sense to everybody? Okay. So why did this catch on? Well, because there's a real pain in the neck to try to collect a 24-hour urine. And this way, if you have estimated GFR that comes back with your basic metabolic panel, you notice the number and you say, oops, they got kidney disease. And that way we diagnose kidney disease earlier, because diagnosing it earlier, these days, in most patients, we can slow down the progression of disease. This is the famous CKD Heat Map. How many people have seen this before? How many people understand it? Nobody. No, Calvin understands it. Okay, here's the idea. You go up to the top line, that's a normal estimated GFR of greater than 90. Let's see if I can figure out how to use this thing. I can't. Just look at the top. You only have kidney disease if you also have proteinuria. That's true for stage 2 also. So if you have a GFR between 60 and 90, so if that collected creatinine clearance was true and he didn't have proteinuria, then he would not, by that standard, have chronic kidney disease. That's really important. Never write down the chart someone has chronic kidney disease until they get to 3, or they have significant proteinuria, or you know that they have something like polycystic kidney disease, or they've had a renal transplant. Okay, please remember that. Now, once you get to 3A, you can say they have chronic kidney disease. Although, if you talk to nephrologists, especially practicing nephrologists, when you get people my age and older, they're not sure that 3A is really kidney disease, especially if there's not also proteinuria and something else that makes you think of kidney disease. There are a lot of people who have estimated GFRs in the 50s for years and years, and it doesn't really go down. So don't get too excited about 3A, and the complications don't start till 3B. But you can notice that there are 2 things that get us excited in the heat map: the lower the GFR and the more the proteinuria. Okay, how many people have heard of Cockroft-Gault? So Cockroft-Gault is what the PharmDs use at the VA. And what they did, this was a VA study of mostly white men. They did 24-hour urine collections and did I think they did an inulin test also. They used weight and age as a variable, and they produced a 24-hour urine creatinine regression formula. And this is actually the formula. It's 28 minus 0.2 times the age times the weight in kilograms. That's how much creatinine you're supposed to produce in 24 hours. Therefore, the estimated GFR, and I could show you the math, but it'd bore the hell out of you, ends up being 140 minus the age times the weight in kilograms divided by the serum creatinine. They empirically said that men have about 15% more muscle mass at the same weight as women, so you subtract 15% for women. They never validated that as far as I can tell. It's still used at the VA. It's challenging though when you have a lot of obesity. I mean, do you readjust it for lean body mass, and how do you adjust for lean body mass? It's still favored by PharmDs, but almost no one uses it anymore. But that's the first one we had, and we had that I think in the early 80s. I think MDRD is still used by many labs, and the idea here is let's get rid of weight and just say for age and gender, on average, we can figure out what your muscle mass is. And that formula, until everybody was carrying a computer around in their pocket, it couldn't be used. But the labs could do it. and the labs did do it. The advantage here is that you don't need to know the weight. The disadvantage is it doesn't take muscle mass into account. So it just assumes everybody has the same muscle mass. All 72-year-old men have the same muscle mass. It's not true. They also found on average, again, this is on average, that women have less muscle mass and African Americans have more muscle mass. This has led to a great controversy, and we'll get to that controversy in a second. And CKD-EPI, the first CKD-EPI came out in '09. And what they did is they collected a lot more data than MDRD did. MDRD was the modifying diet and renal disease. And they produced the formula because they had a lot of 24-hour urines and a lot of inulin clearances. And this one is almost as complicated, CKD-EPI. Again, they put race in there. What they don't say in here is that many other countries have produced different formulas based upon the muscle mass of that population. It's been different in Asia and other places. And so this really became, because we're dealing with averages, on average it may be valid, but for the particular patient, it's not so valid. And that's the problem of not having some kind of weight adjustment, and the problem with using muscle mass as the way we figure out what the kidneys are doing. Does that make sense to everybody? You're not disagreeing, so I guess I'm okay. In 2021, they redid the formula and made it race neutral. But they did continue to include an adjustment for women based finally on collecting enough data in women so that on average, that's right. But just like men, some women have more muscle mass than others at the same age, and some men do. We'll talk about all this now. So if we're gonna do an estimated GFR, these are the assumptions that we have to have. Number one, it has to be a stable serum creatinine. If someone comes in and normally has a creatinine of 1.2, and today they have 1.8, and you tell me the estimated GFR, I'll laugh at you, because I don't know if that's a stable creatinine. And the assumption is that you have a stable serum creatinine, because it's in the denominator. So for example, let's take Glenn. Let's say I cut out both of his kidneys. Let's say his creatinine is 1 today. Tomorrow his creatinine is 2. That doesn't mean his GFR has only gone from 120 to 60, because he has no GFR, because he doesn't have any kidneys. So a changing creatinine makes it impossible to use estimated GFR. So let me tell you the story of, did I get it? No. So we have average size, so you can look at your patients, and those patients who were 360 estimated GFRs were little cachectic men. It's not accurate with either increased or decreased muscle mass, and I'm going to give you an example of that. Our patient had markedly, and Ann can tell you because she saw the patient after me, had markedly decreased muscle mass and an amputation, and therefore the estimated GFR we knew had to be some kind of an overestimate for GFR. But you couldn't tell from his creatinine. You had to actually understand where all this comes from. Let me tell you the story of Cliff. Cliff was my medical student maybe 15 years ago. He's an anesthesiologist now, really, really good guy. During his second year of medical school here, he studied and worked out. That's about all he did. He studied and worked out. And he worked out, as his friends would say, until he puked. He really put on muscle. He went to student health for routine something or other. They checked his creatinine, and his creatinine was 1.5. And they told him that it looked like he probably had kidney disease. He was smart enough to know he didn't have kidney disease, but they did a bunch of tests. And the question is, does he really have early CKD? As a third-year student, he worked real hard, but didn't have as much time to work out. So he decreased muscle mass by about 10 to 20 pounds during the third year, and his creatinine went down to 1.1. And this is not a made-up story. This is a real guy. People who are bodybuilders, many NFL football players, if you use an estimated eGFR calculation on them, because their muscle mass is so much larger, it's going to look like their GFR is decreased. And so once we got him to his normal weight, his estimated GFR is fairly accurate. Okay. In our patient, we didn't think we could use estimated GFR. We knew his muscle mass was down. We weren't sure about a 24-hour urine collection with this guy for a variety of reasons. The controversy over race is now removed from CKD-EPI, probably still pleasant MDRD. And the problem with having the race attached to estimated GFR was that it falsely elevated the estimated GFR in some African Americans. And that's because nobody could eyeball someone and say, is this somebody who's bulked up a little bit or not? Because it's just using averages. If you have that problem, plan B is what we're going to go to. The assumption of average muscle.
You don't have a lot of science and you add stuff together.
What is that? Okay, am I okay again? Okay, the assumption of average muscle mass is what I want you to all keep in mind all the time. Therefore, if you have a cord injury patient, you're going to overestimate GFR. Cachectic patients like ours, major amputations, and then also bulked up patients. And now this thing doesn't work because we had to play with the mouse. So about over the last 15 to 20 years, I've been reading about cystatin C as an alternative. It's a low molecular mass plasma protein that's freely filtered throughout the glomerulus and almost completely reabsorbed and catabolized by tubular cells. It's been proposed as a new and very sensitive serum marker for changes in GFR. It has nothing to do with muscle mass. So the CKD-EPI people have a formula which you can find on MD Calc or any of the calculators or on the many websites, including their websites. So this is really the take-home message. Estimating GFR is very complex, and it's our job as internists to understand when we may be misled by the estimated GFR. Just because it shows up in the BMP and it's written down as if it's a real number, it's not a real number. It's a made-up number. And it's a number that we have to adjust for. And if we don't really understand it, cystatin C is probably going to be a much better way to do it. And I know there's some people in the renal division who feel strongly about that also. I also know that for those people in med-peds, the pediatricians like cystatin C also in any situation in which it's confusing. Remember the assumptions for estimated GFR from creatinine. It's got to be a stable creatinine, and the patient has to look normal for their age and gender. When in doubt, go to cystatin C now. It really may give you a better idea of the situation, it still will be inaccurate if you're changing in volume status or you think they have acute kidney injury and their creatinine is going up real fast. The assumptions will still fall apart there. But it's really a simple test to get, a useful test to get, and something that in 2022 you can even get at the VA. It's highly recommended. I've done 2 podcasts on this, one called Estimating Glomerular Filtration Rate. One of the chairs of the CKD-EPI panel, Neil Poe, who is the chief of medicine at San Francisco General, is my guest on that one. And we go through all of this in quite depth. And then we did another one called Should Race Be Part of Glomerular Filtration Rate Estimation? And went through all the reasons that that's really not a good idea for patients to use that, which is why we now have the race neutral estimated GFR for creatinine, but also cystatin C solves the problem of many other groups that are either over or underestimated by creatinine. I'll be more than glad to take questions, and maybe, Anne, you can help me figure out how to see if the chat has, well, we got one question in chat. Feedback on Zoom, mute everyone. Does anybody have any questions? Yes, Will. Yeah, so as soon as you put CKD in the chart, that impacts their ability to get life insurance. And so having a GFR above 60, unless they have significant proteinuria or you know they have polycystic kidney disease, you're not supposed to write, you're not supposed to call that chronic kidney disease. That's what their GFR is. And so it's one of those fine points, and some people don't even write it down for 3A if there's no proteinuria. Now, this guy had proteinuria, he had diabetes, and whether he's stage 3B or stage 3A, you know, he's somewhere in between, but he has significant kidney disease. That's the one thing we know, is that he has significant kidney disease. We deduced that because he had a type 4 RTA, and that's so common in people with diabetic kidney disease because it so often affects the juxtaglomerular apparatus. Any other questions? Yes.
Earlier in the podcast, you said that whenever you estimate GFR, you tend to use substances that aren't reabsorbed or secreted.
Right.
So with this most recent study, I think like one of the last sets, it's like almost completely reabsorbed by the kidney.
It's reabsorbed, but because we're not measuring the reabsorption, it's as if it went into the urine. So if we're collecting this is for 24-hour urine clearance. We're doing a different type of clearance for this guy with cystatin C. So it doesn't assume a lot of it doesn't assume cystatin C in the urine. It's metabolized before it gets there, but it is almost perfectly filtered. Does that make sense? I think that sounds confusing. It's a serum test. It's pure serum test. Just pure serum test. You don't collect a 24-hour urine for cystatin C. You just, there's a formula and it's been highly, highly validated. And so if there's any doubt in your mind now, and I think many of the nephrologists here agree with me, there's any doubt, just go ahead and get a cystatin C. If you're trying to figure out if they have kidney disease or not, and how bad it is. And I would do that in VA clinic also. If you have someone who has a creatinine that suggests an estimated GFR of 40, but you think maybe they're a little bit muscular or something like that, and you're trying to really figure out where you go many nephrologists and many experts are now recommending to go ahead and order cystatin C. We don't need it in most of our patients because it's just not a concern in most of our patients. The only reason it was a concern here was because of the type 4 RTA. That's why we got so excited about trying to figure out his estimated, what his GFR probably was. And we think it's probably the cystatin C GFR. Any other questions? Please don't write that I didn't do a good job because I finished early. An extra good job. So you all socialize, have a good time, and get back to work whenever you have to. So hopefully you can get home and enjoy the rest of the day.